Hello everyone, welcome to the AACR Cancer Health Disparities Conference YouTube Live. I'm Dr. Brian Rivers, Director of the Cancer Health Equity Institute at Morehouse School of Medicine. And we are here live in New Orleans. Before we bring Dr. Gomez in, I just want to talk briefly about some of the highlights. We're in the third day of the meeting, and it has been an outstanding meeting so far. For our opening session, we have the Director of the National Cancer Institute, Dr. Norman Sharpless. And then we also had the opportunity to award the 9th Annual Distinguished Lecture on the Science of Cancer Health Disparities, supported by a generous grant from the Susan G. Komen. And the recipient this year was Dr. Shanita Hughes Halbert from the Medical University of South Carolina. But even more so, and I thought it was a unique treat for this meeting, it was actually the first time it actually took place at this meeting, was the elevation of the role of our advocates and the role of community. And we're gonna hear from one special one who's with us today, but for the first time, the advocates opened up the Cancer Health Disparities meeting. How exciting was that? I saw wet eyes, I saw smiles, I saw elation in the room because it really puts the face to why we're here and why we do the things that we do toward advancing the reduction and elimination of cancer health disparities. And so with me, I have Dr. Scarlett Lynn Gomez. She's our first panelist, and she is a professor in the Department of Epidemiology and Biostats at the University of California, San Francisco. So Dr. Gomez.
Dr. Rivers.
You chaired a session at the meeting on cancer health disparities among Asian American, Native Hawaiian, Pacific Islanders. Can you please explain what disparities are experienced by these populations in particular, and why it's a focus of this meeting?
Sure. In fact, I liked that you brought up the presence of the advocates at this conference, and in fact the work that many of us have been doing in this area and trying to understand and document cancer health disparities among this population of Asian Americans, Native Hawaiians, and Pacific Islanders is largely driven by advocate work. Specifically, and we have one of the advocates who personally inspired my work, who will be speaking at my session today, and she has been a staunch advocate based on driven by her personal experience to advocate for disaggregated cancer statistic data. I'm not sure if everyone knows, I personally was surprised. This population comprises persons from more than 30 different countries. Wow. And traditionally, up until only very recently, statistics have been combined for this diverse population. And so when you ask about what disparities are out there, we actually are just starting to understand what these disparities are. Some examples of these disparities are high rising incidence rates of breast cancer that we're seeing among Chinese, Filipinas, South Asians, and Southeast Asians. And this is unusual because this is in stark contrast to declining rates of breast cancer among other populations. Another disparity is the high rates of lung cancer that we see among Asian American women who've never smoked. In fact, upwards of 70%, maybe 80% of some Asian American women ethnic groups don't have a history of smoking, yet they developed lung cancer.
Wow, very interesting. So, I realize you said that, the research is still developing as it relates to causality of some of these disparities, but do we have any suggestions or any indications as to, what are some of the causes of these disparities?
Mm-hmm. I think that they're likely multifactorial, meaning that there's multiple factors that are contributing. So a lot of these are likely unique to the cultures and the backgrounds that these populations come from. And I think that they're multi-level. The factors range from things that we experience within our societies, within our neighborhoods, within our families, all the way down to the biology, and there may be unique biology in some of these population groups. So it really will take a very creative and a unique approach to studying what some of these underlying problems are, and this is going to be reflected in some of the talks that are going to be presented at this session. As an example, we're doing a study, and this will be a talk that my colleague will be presenting in my session. We're addressing the question of high lung cancer rates among Asian American women. We're taking the approach of a large integrated data approach of integrating together electronic health records data on 4 million people, together with cancer registry data, together with environmental data, to try to see if we can understand what of these multiple factors across the different levels contribute to the high rates of lung cancer in Asian American women.
Wow, that is extremely fascinating. I'm looking forward to your session. I think another unique feature of this particular meeting is that it attracts individuals from a variety of disciplines.
Absolutely.
And so this session that you just referenced seems like one of those sessions that really attracts some of the what we call unusual suspects at the table. Beyond the typical biomedical scientist or the public health type individual, who's going to be helping you with all this data crunching?
This is where multidisciplinary sciences are really important. It's not going to be me.
Okay.
I can tell you that.
Okay.
We need bioinformatics. We need data scientists. And these are emerging fields in the area. And we as epidemiologists and social scientists and molecular epidemiologists and geneticists need to learn to work together with these different disciplines to be able to move the science forward.
Incredible. Well, thanks a
Thank
lot,
you.
Dr. Gomez, and best wishes on your session this afternoon. Thank you for joining us. All right, so our next panelist is Dr. Augusto Ochoa, Director of Louisiana State University Health Science Center, Stanley S. Scott Cancer Center, located right here in New Orleans, Louisiana. And Dr. Ochoa, welcome.
Thank you very much.
And thank you for hosting us. He's been a tremendous host thus far. We've had some great food, some great dinners, and it's just been an excellent venue for the meeting.
It's been a tremendous pleasure, and it's been a fantastic meeting all the time.
Awesome. So, Dr. Ochoa, one of the talks in the session you chaired at the meeting focused on colorectal cancer disparities in Louisiana in particular. Can you tell us a little bit about these disparities and the challenges with eliminating them?
So in addition to just having a higher incidence and mortality from colorectal cancer among all our population, both African Americans and Caucasians, we have a disproportionate death and mortality from colorectal cancer in African American patients. And one of the major challenges that we face is the problem of screening. So we are, as other places have shown, once you start increasing the number of normal individuals that are being screened, you detect early stages of the disease, and so you can treat appropriately and decrease the mortality. But the screening rates among our patients in general, and our population in general, for colorectal cancer and other cancers is relatively low. But colorectal cancer especially is a problem, as everybody knows. Talking to normal individuals or individuals who feel normal, to conduct the screening test, the FIT test, or to do a colonoscopy is a big problem. But in addition to just talking to the patient and convincing him or her that they need to be screened, we have a problem with the number of GI specialists who are willing to do the colonoscopies or who can perform the colonoscopies. There's areas in the state that have very few of these qualified physicians, and so the state of Louisiana, led by the Secretary of Health, actually has developed a task force with the idea of finding ways of tackling this problem.
I see. And so will this task force be charged with developing strategies at the patient level or also the provider level or even the community?
So those are very important questions, and actually the task force includes members of all of those groups that you mentioned. So both physicians, providers, navigators, and members of the community are part of that, and actually patient advocates, survivors are part of that whole process.
And what are some of the principal barriers that you have found here in Louisiana that present themselves as impediments to screening?
So it depends on the patient population, but I think in general the impediments for participation in any one of the screening programs, it starts with first of all access to healthcare. Second, understanding literacy is very important. What do our patients understand by screening? When do they need to be screened? And why does a person who feels normal need to be screened after a certain period of time? That's one thing. The other part, obviously, as we mentioned, was who is going to reimburse for the screening. So we have ongoing programs. We have a very good program for cervical cancer screening, for breast cancer screening, funded by the CDC. We've now started this program with colorectal screening that is in process. And the next one that is going to be coming on board is going to be prostate cancer screening. So the state, in association with federal organizations, is trying to move this process forward. We have ongoing research, as you've heard in our presentations, we have ongoing research trying to understand the problem of health literacy. And health literacy is not just a black and white problem, it's actually more of a poor, the areas of poverty have a problem of health literacy overall. And so we're trying to address that because that has to be culturally appropriately done and evaluated and studied, and we're trying to move in those fronts.
Excellent. Those sounds like very viable strategies. And then one last question, because I know you have to go back to the excellent science that is being presented here at the meeting. I think it was on Friday or Saturday, in your remarks, you referenced New Orleans or Louisiana as the epicenter for cancer health disparities. Can you expound on that?
If one simply looks at the maps that the CDC and the National Cancer Institute put out on a yearly basis based on the tumor registries, and they color these maps essentially for high incidence and high mortality of cancer overall, the highest incidence and mortality, although it's spread throughout the United States in different places, the one that is consistently there for highest incidence and mortality is Mississippi, Louisiana, and Arkansas. That trio is right there all the time in red, both for incidence and mortality. And if you then start looking at the individual tumors and how this disparities or how this incidence and mortality affects the different races, it becomes even more significant. If one looks at prostate cancer mortality, for example, it's 148% higher in African Americans than in Caucasians. So these are the kinds of disparities that we need to be aware, that we need to study, so that we can develop appropriate approaches to tackle them.
Excellent. Dr. Ochoa,
Thank you so much.
Thanks so much for joining us, and thanks for hosting us.
It's been a pleasure.
Have a great day. Okay, so we're moving right along. Our next panelist is Dr. Laura Federman, Associate Professor at the University of California, San Francisco School of Medicine. Good afternoon, Laura. How are you?
Hello, how are you, Brian?
Excellent. And Dr. Federman is also incoming chairperson for the Minorities in Cancer Research Council within AACR. So Dr. Federman, you chaired a session at the meeting on global cancer health disparities, and I know you do a tremendous amount of work in this regard. What research on global cancer health disparities, what have we learned from that approach as it relates to addressing disparities? And then how can we take those lessons learned and apply them to some of the disparities that we're seeing here in the United States?
So first of all, let me, I think the most important point for me to make is that global cancer health disparities has to be thought as a, not from a what we can learn about disparities in the US only perspective, but actually as a humanitarian community as cancer health disparities researchers, because the same way that you would come up with a vaccine for a devastating disease and then make sure that countries like Africa or Latin America can access those vaccines and can provide them to the population, we want the same thing with precision medicine in cancer, for example. So we're coming up with all these great solutions, and we're coming out with all these ways to treat patients in the US, but are we making sure that in other places with less resources, they are having the ability to do the same? So that was, I just want to make sure that we are all share this perspective. But on the other hand, working in other countries can help us a lot to learn about the genetic and environmental factors that contribute to health disparities in the US. So by learning from the genetics of breast cancer in Africa, we can for sure contribute to learning about why African American women have, for example, a higher frequency of triple negative breast cancer.
Okay. That's excellent. And you bring up a very, very important point in terms of the models that you're employing toward examining and better understanding these disparities, looking at the gene-environment interaction, an environment meaning the social context. Do you see parallels in the environment of, just say, in Colombia versus the Colombians that actually relocate or move to the United States? Are there parallels that you see in terms of the retention of their culture that may ultimately impact their genome, in terms of their dietary patterns or other behaviors that are often affiliated with their culture? Do you see any differences or any parallels?
So I can tell you about some work done in the Mexican Americans, where we are trying to look, for example, are there any differences in environmental exposures between first generation and second generation of immigrants that could explain the increase? It's almost twice as high the risk of developing breast cancer in the second generation than in the Mexican women that were born in Mexico. So where you can try to think about what is it that is going on when you move to the US, that after 1 or 2 generations, all of a sudden your risk is double. Right. And so you can adjust for the genetics in a way, there shouldn't be a lot of difference in the genetics between the Mexicans in Mexico and the Mexicans in the US. Okay. So you can match for that and then say, are we still seeing differences in the incidence of the disease? And that has to be due to environmental factors. And we know about certain things that definitely change when you move to this country. Okay. Latina women tend to drink more. They have less number of kids, they don't breastfeed as much, which are all factors that we know contribute to breast cancer risk. So I think working in Latin America and with Latinas in the US, it's a great way to disentangle the relationship between behavioral, cultural factors, environmental exposures, and the genome.
Amazing work, amazing work. One last question, because I know you also have to get back to a session. What progress have we made in understanding what role genetic ancestry plays in causing cancer health disparities?
I think we've made a lot of progress, and I feel there's a lot of progress to be made.
Okay.
So, for example, we know now that for prostate cancer, my colleague Rick Kittles has shown for a while that ancestry is related with prostate cancer risk, and we know that African American men who are of higher African ancestry have more aggressive disease, and now he's working on looking at the vitamin D and how that relates to African ancestry and to aggression in prostate cancer. Also, Lisa Newman and Melissa Davis, they work on breast cancer in African American women, focusing on triple negative, and they are showing how some of the genetics associated with the African component can contribute to the tumor subtype predisposition. And then there's my own work with Elad Ziv as well on the genetics of breast cancer in Latinas, where we actually in 2014 we found a protective variant that explains partly why women with indigenous American ancestry from Latin America have actually a lower risk of developing breast cancer.
Wow, interesting, amazing work. Well, congratulations on all the strides you're making toward the elimination of cancer health disparities. Best wishes on your session this afternoon, and thanks for joining us this afternoon.
Thank you, Brian.
Okay. And then our final panelist is Sheila McClown, cancer health advocate from St. Louis Breast Cancer Foundation. Welcome.
Thank you.
Is this your first time at an AACR meeting?
No, I came earlier this year to the conference, to the annual meeting.
Oh, in Chicago?
Yes.
Oh, excellent. So you're a pro then.
Well.
Are you enjoying yourself?
Learning.
Are you
Yes,
enjoying
I'm having
yourself?
a good time.
Are you seeing differences between the two meetings, the disparities
yes, it was
meeting?
so many people.
Where, at the annual meeting?
At the annual meeting.
Wow,
and this
incredible.
Is more, intimate.
Excellent.
Yes.
Well, Sheila's goal is to lobby for metastatic breast cancer patients, veterans, as well as African American men and women. She also works with Living Beyond Breast Cancer and Fourth Angel Mentoring Program as a mentor. McClown will be a consumer reviewer.
Yes.
Wow. For the DoD Breast Cancer Research Program.
Yes.
It's pretty prestigious.
I love that program.
Awesome. So can you share your personal experience with cancer and then talk about how advances in cancer research have helped you with managing your disease?
Yes, back in December 2009, I was diagnosed with metastatic breast cancer. So I've been living with this disease for 9 years. So I'm walking proof that research works.
Congratulations.
Yes, I've been on 5 different treatment plans, and Herceptin, which is out of the DoD Breast Cancer Research Program, is helping me. It helped me stay alive. Just recently, it stopped progressing again on my 4th rib, and I'm on a clinical trial, and I'm proud to say I'm on a clinical trial. And it wasn't a last resort that I had to be on a clinical trial, but I trust my doctor. We have a great, and I always tell patient advocates and patients, period, to have that physician patient relationship, because it's very important. Last night when I was presenting my poster, somebody asked me, well, what convinced you to go on a clinical trial? And I didn't need to be convinced because I trust my doctor. And she recommended the clinical trial, and Monday I'll be on my 5th cycle, and it's already stable again. So clinical trials work. These are life-saving medicines. And you know, I always tell African American women and men that we need to be a part of clinical trials. You can't have 100 people on a clinical trial and only 5 Black women or men that are participate. That's not a cross-section of breast cancer. You know, statistically, we're dying at a 42% faster rate than any other race. So if we want to find out why, you know, we need people to participate in clinical trials, and I'm living proof that research works. My mom, who died, she was diagnosed with metastatic breast cancer in 2001, and she died in 2004. So her life expectancy was 3 to 5, you know, they give us 3 to 5 years. I've outlived that, and they call me an exceptional responder. But, you know, I'm blessed, you know, that, you know, I have these opportunities, these clinical trials and research that's keeping me alive. And that's why I love the DoD breast cancer research program so much, because it's helping veterans, because I'm a 25-year Air Force veteran, and it's helping men, it's helping women, because 1% of men get breast cancer as well. So it's just very, very important that we participate in research, and we continue to keep the conversation open, especially in the African American community.
Wow, amazing strength and what amazing testimony. I mean, while you're going through the process of healing,
Yes.
you know, at the same time you find time to be an advocate.
Yes.
And that's why you're here at this meeting in
Yes.
that capacity. And even doing a scientific poster as well.
Yes, sir.
Still getting the word
I
out.
was nervous about that, but
Oh, but you did so well.
Yes, thank you.
did so well. I've been hearing others talk about it.
Thank you.
And I know we had a fantastic session this morning on advocating from the bench.
Yes.
And we had some phenomenal speakers, and I know you were in the audience. What were your perspectives from the session this morning? And then why is it so important for you to be an advocate?
Because I think the African American community needs to see people like myself, I don't want to say that I'm the face of breast cancer, but need to see African American women and men speaking out. You know, someone said to me yesterday that when they see the pink ribbon, they see white women. Because when my mom was diagnosed with breast cancer, I didn't know any other Black women that had breast cancer. It was never talked about. And then when I was diagnosed, I didn't know any Black women, you know, that had stage 4 breast cancer. I didn't even know metastatic meant stage 4. So it's important for patient advocates to be out in the community, to be out in churches, and just speak about our experiences, speak about patient advocacy, how important it is, and to speak about just how important it is for us to be out there educating our communities, you know, like I said, I love talking to veterans because, you know, veterans, we get breast cancer too, you know. So it's just important, you know, this morning was so powerful. You know, I was just like, yes, you know, somebody understands it, somebody gets it, somebody gets, you know, what living with stage 4 breast cancer, you know, somebody gets that we need research. We don't need any more pink ribbons. I know we educated about breast cancer. We need more research, the moonshot and you know, all the different organizations that are raising money for research. You know, I'm just honored, you know, and I want people to see, man, Sheila's lived 9 years, you know, when they go into their labs. And I want them to think about my story, and I want them to hear my story. And when they're thinking about it, man, you know, what I'm doing in this lab is helping women live longer and to have a better quality of life and to live longer with their families. And I always, you know, tell, you know, I have 3 sisters, you know, just let me be the person that gets this disease and nobody else in my family. You know, just let me be that one person where, you know, we can, you know, it's such an honor to be on this clinical trial because I'm helping other women and I'm helping researchers understand, you know, why it progressed or why I'm living longer, you know. So it's just important, and just to hear people speaking this morning, I was just like, man, yes, they get it, you know. So it's just important for me to be there.
Wow. Well, truly, you are amazing, and you have incredible strength, and congratulations.
Thank you. About to make me cry.
Wow, I really appreciate you freely sharing your testimony. I mean, I was tearing up as well, but I mean, just the strength that is before me is indeed incredible, and best wishes going forward. And if there's anything I think the survivorship community can do here to help you, feel free to call us.
Thank you, sir.
Excellent. Well, thanks for being with us, and thanks for being at this meeting.
Thank you for being an excellent moderator.
Oh, well, thank you. All right. And with that, we'd like to conclude our YouTube Live from New Orleans, Louisiana, at the 11th Annual Cancer Health Disparities Meeting. Join us next year. We'll be in San Francisco for the 12th Annual Cancer Health Disparities Meeting, and our very own Dr. Laura Fetterman will be leading us to another fantastic meeting. Signing off.